Welcome to this week's video on Pulmonology Read Aloud. Thank you very much for your overwhelming response on the COPD Gold Guideline video. And as per your own interest and your recommendations, I'm back with the new series of videos on CT scans of chest. Now, since it's a very big topic and I want to be as realistic and as simple as possible in my explanations. So I have decided to divide this into practical topics. Remember, this channel is Pulmonology Read Aloud, so I would like to bring to you content which is based on an evidence which is easily available for you to download, to read further. And so I usually try to take articles and topics and published guidelines and present to you so that you get the most scientific material. So, having said that, today I'll be reading aloud this very nice article which was published in Indian Journal of Radiological Imaging in 2019, which talked about imaging protocols for CT chest and the recommendations. I think before we discuss the various signs and appearances on CT scan in various diseases, it's important to understand when and where a CT scan needs to be offered, in which format and which protocol, because there's usually a lot of confusion around it. So the first video in this series would be on imaging protocols. We've all heard of the two main protocols, the non-contrast CT chest and the contrast enhanced CT chest. And we all have used further modification of the non-contrast CT chest, which is called a high resolution CT chest or HRCT chest. Remember that CT scanning usually acquires the various images in two modes. One is a volumetric mode in which a patient takes a full inspiration, and one is a sequential mode which is used in expiratory scans where sequentially a small part of the lung will be scanned and then the second part will be moved on to. Now, since CT scans or computed tomography forms the workhorse of imaging evaluation, it's very important to know where, which scan and which protocol of these needs to be ordered, because there is an increasing concern of radiation exposure, especially in young individuals. And since we're using iodinated contrast material in a lot of patients, we should be more wary of the fact that contrast is actually required in such patients, especially when you require repeated imaging. So, what are the imaging protocols? The non-contrast CT chest protocol includes a routine non-contrast CT chest, a low-dose CT chest, another term called ultra-low-dose CT chest, and cine CT. The contrast enhanced protocols include routine CECT and perfusion protocols or angiography protocols. The angiography protocols we know of CTPA or CT pulmonary angiography, CTA or CT angiography combined protocols. There are two more called split bolus and triple rule out, which have specific indications. Whenever we are looking for masses and nodules, we prefer a dynamic CT, a multiphasic CT, and perfusion CTs to see the penetration and to see whether these are more vascular or not. Let's discuss the indications where we would use a particular protocol in a CT chest. So, if you are screening a patient as part of lung cancer detection, or you're looking for a patient where you just want to know whether he can be screened for a nodule, we would preferably do a non-contrast CT at that time, and we can do a low dose CT. We do not need to give IV contrast unless we do actually see a nodule and we want to further look at it. When we are screening for metastasis, again, we don't need to do a contrast every time, so we can do a non-contrast CT. If your patient comes as a suspected case of interstitial lung disease, you do not need a contrast medium. You can do a non-contrast CT with HRCT cuts in such a patient, and even in a follow-up ILD, you do not need a contrast agent. For patients suspected of airway diseases, bronchiectasis, again, a non-contrast CT is sufficient. However, when you're looking at patients where there is a consolidation or there is a mass lesion or there is a mediastinal involvement, where you also want to know about the vascularity of structures or you want a better definition of those structures, then we would prefer a contrast CT chest. So if you're looking to scan a person of PUO, you would want to do a contrast CT of the chest and abdomen because you may get focus either way. If you're looking at non-resolving pneumonias, suspected masses, mediastinal widening, malignant effusions or chest wall diseases, and when you're looking at staging of cancers or staging of lymphomas, in that case you may want to do a contrast enhanced CT scan of the chest. So, in continuation with suspected patients for lung cancer, even if you're ruling out an unexplained vocal cord palsy or evaluating an SPN or solitary pulmonary nodule, you would prefer a contrast enhanced CT, along with patients where you have trauma, where you want to know the situation in the vessels, you would prefer to do a contrast enhanced CT. Patients where you have hemopsis, here CT angiography plays an important role. Also in patients with atypical chest pains, where you are suspecting causes other than coronary syndrome, such as a pulmonary embolism or aortic dissection, again in angiography. And patients with pulmonary embolism, we know a CT pulmonary angiogram is almost the gold standard. So this is how we really divide as to which one will need a contrast and which will not. Coming to the non-contrast CT chest, if you see, then the most common indications where a non-contrast CT would be done would be patients where you are doing the CT for infections, bronchiectasis, for interstitial lung disease, and patients where you just want to screen for metastasis or patients where you need to follow up. These are the most common indications. However, if we go in a little detail, then you would see that if you do a routine NCCT for suspected METs or ILDs or bronchiectasis, or in case you cannot give a contrast because the patient has renal failure, in such patients, you can use a non-contrast CT. Certain cases where you need to repeat CTs frequently, such as in ILD evaluations for low-dose lung cancer screening, for following up a patient, you can do a low-dose CT scan, which uses lesser exposure, less millisieverts of exposure also, and in ultra low dose CT is another modality where you can give even lower contrast. Acquisition is less, so the safety is much better. This can be done again as part of lung cancer screening in selected populations. Let's look at these CT images. The images above and below both are non-contrast, but you can see that there is a beautiful difference in these two images. Even this is non-contrast, however this one is much more clearer. This is a HR image, so high resolution image of the non-contrast. So this has been processed. Now a non-contrast CT essentially starts acquiring volumetric data. It starts at the thoracic inlet and it includes, classically must include the upper abdomen also. Now here if you see, whenever you do the scan, then it is done in supine position in deep inspiration, and the patient is asked to keep his arms extended overhead because that avoids artifacts. Also, we get both the images here. You see this is the lung window and this is the mediastinal window. And now the same scan, when it is further modified and processed, we get the high resolution images which are much better after using a high resolution reconstruction algorithm. So what is high resolution reconstruction? We know HRCT refers to as one, basically those scanned images where the images are taken at 1 millimeter cuts, right? So nowadays We do not need a separate HRCT acquisition in most scanners. All the acquired CT images in a non-contrast CT can be reconstructed to give us an HRCT configuration, right? So a 60 to 80 kernel reconstruction becomes high resolution CT. So you do not need to ask for sequential mode CT again. But there are certain scanners where they may not be available, and so it may have to be reconstructed. The classic HRCT lung images windows usually is 1 to 2 mm. So 1 to 2 mm section thickness, which is enough for interpretation. And of this, the soft tissue mediastinal window is 20-30 kernel and the lung window is 60 to 80 kernel. So that's the specification. The images are acquired at 10-10 mm interval, but each section is 1 to 2 millimeters. So that's important, and the way it works is that it really helps us in evaluation of diffuse lung diseases. So we've all seen this as pulmonologists. So again, just reiterating that HRCT reconstruction algorithm sharpens the images, makes them more clear, gives us images at lesser sequential depth, so we are able to scan the lungs in a better way. This is something which is another post-processing image. So all the non-contrast CT images, the volumetric data which is achieved can be further processed, and this gives us further images, of which the first one that you see on the screen, these are multiplanar reconstruction images, the MPRs, okay? So in different planes, the images are reconstructed. Again, helps in diagnosing diffuse lung diseases. This, the other image that we see is the MIP images or maximum intensity projection images, and we also can get MINIP or minimum intensity projection images, and a virtual bronchography or a virtual bronchoscopy can also be done by rendered images to evaluate airway. So everything can be derived from a non-contrast image. When do we use MINIPs and MIP images? So when we want to evaluate the airway, we do a minimum intensity projection. We don't want to see the parenchyma, we want to see the airway. So minimum intensity projection for airways evaluation, and MIP images or maximum intensity projection we want to do for ILDs, for nodules, so for nodule identification specifically. Coming to another terminology called expiratory scans. So an expiratory scan is taken at the end of expiration. It may include contiguous acquisition. Just like a supine inspiratory scan, you can ask the patient to start expiring and you can take a contiguous acquisition, or in the form of a sequential acquisition where it will involve the upper trachea, carina, the lung bases and up to the diaphragm. So sequentially we can capture the expiratory phase. Now, basically, if you do sequential stepwise, you can just concentrate on doing the expiratory images for areas where you suspect a problem. So there's less radiation. So we prefer sequential stepwise rather than the whole volumetric. But if it's an elderly patient, he cannot breath hold, then we do it in a contiguous phase. Common indications for expiratory scans are suspected air trapping, small airway disease and tracheobronchomalacia. So it's very useful in interstitial lung disease like hypersensitivity pneumonitis, in small airway diseases where we want to look at air trapping. When do we request this? We request for an expiratory scan when we see ground glass opacities because we want to rule out whether there is air trapping here or not. When we see a mosaic pattern, we should do an expiratory scan. And when we are suspecting an airway dominant disease, we should do an expiratory scan. So these are few images. If you see, this is an inspiratory scan. It did show some mosaic attenuation. There was a different attenuation in different parts. And then the same patient underwent the expiratory scan. So when this patient undergoes the expiratory scan, first thing to look out for is that the airway, this is the expiratory phase because the posterior walls of the bronchi are bowing. So this confirms that it was an expiratory and not an inspiratory image. And here, if you see, there are multiple areas of black and gray alternating. So it suggests air trapping. The black arrow is air trapping. And so, again, it helps in the diagnosis. Another terminology we commonly use is prone scans. Prone scans are usually used in early ILDs or in ILAs, interstitial lung abnormalities. Whenever you see an interstitial markings which are dependent in the lower lobe, in the same area of interest, we can take a cut where we ask the patient to become prone. So here if you see this shows ground glass opacity in the posterior basal segments of both lower lobes. You do a prone position and it clears the DGOs, which meant that it was just dependent densities. It is not an interstitial lung abnormality. So prone scans are very helpful that ways. The other terminology we use is low dose CT scan. Low dose CT scan basically reduces the exposure of the patient to radiation. It's preferred in patients where you need to repeat the scan again and again. So you can use it in lung cancer screening for nodule detections as well as in ILDs for follow-up. So here for pulmonary nodule follow-up and screening, we can use it. What is it actually? Here the radiation exposure is less. So you would use tube current less than 100, tube voltage 120 and low, and tube current should be 40 to 80 milliamperes between that, and that's called a low dose CT scan. Here you see low dose CT scan images. In this patient, a low dose CT scan image done at a difference of 6 months in a chronic smoker. Here you see a nodule and then you repeat 6 months later, the nodule is of the same size. Now since it's a nodule, let's apply the MIP image, and when you apply the MIP image, you see one more nodule here which was not seen earlier. So this nodule in the right lower lobe is another nodule in addition to this which was seen in the MIP image. So this is how reconstruction helps us. Now, there was some controversy of whether a low-dose CT scan reading will change based on your experience as an observer, but they have shown that there's not much difference inter-observer or intra-observer. So low-dose CT can be used compared to a standard dose CT in following up these patients. And there have been various combinations of which voltage, which current to use to call it a low-dose CT. But on an average, the low-dose CT screening can be performed with a dose less than 2 millisieverts and less than 100 milliamperes. For ILD, we want to achieve a dose less than 3 millisieverts, and the ideal scan in an ILD would be 1. A supine scan, 2. It should be sustained and inspiratory, 3. We can do a sustained and expiratory phase, 4. We should ask for a prone scan if you feel there are dependent densities in lower lobes. Image reconstruction should be high resolution for a CT scan, which should be 1 to 2 mm. And you can use post-processing tools like MINIP and MIP to assess low attenuation lesions and nodules also. So these are the axial and the coronal images in a patient with ILD, probably UIP. You can see that when they did a low-dose CT image for this patient, you are getting a good resolution, and they reconstructed it. So you get a craniocaudal and axial distribution of the reticulations, the septal thickening. Here also you can see macro cysts, and this is the MPR reconstruction. So the MPR reconstruction actually shows that there is along the bronchus, there are both macro cysts as well as traction bronchiectasis and honeycombing. So by using reconstructions, we can use a low-dose CT also as well as a conventional CT. How about an ultra-low-dose CT? It reduces the radiation exposure further, less than 1, and it can also be used for screening of lung cancer. There's another terminology called cine CT, basically more for the airways, where the lower trachea and the carina we want to see. It's an alternative diagnostic modality for EDAC, dynamic airway collapse, And in fact, it has been shown to have comparable efficacy, just like a bronchoscopy, which is considered gold standard for dynamic airway collapsibility. You can see this example. Here you can see that the right main bronchus is collapsing more than 50%, suggesting bronchomalacia. This is the inspiratory phase, and the expiratory phase. A cine CT is not a static image, it's actually a moving image, but these are the screenshots. So it's better than pairing a static inspiratory expiratory image. We can use a cine CT. Coming to the last part of my talk, a short discussion on contrast enhanced CT. We know that contrast enhanced CTs can be used for routine CCT chest and also for perfusion scans. When you use a routine CCT, you use an iodine concentration of 300 to 350 milligrams iodine in ml. And when you use perfusion scans or angiography images, you need a slightly higher concentration. How much contrast we give to the patient will depend on patient's weight. In a routine CT, you would ideally use 1 to 1.5 milliliters of the contrast per kg, and you may have to give a higher dose if it's an obese patient and you're asking for angiography. Otherwise, for a routine CT and CT angiogram, you could use similar doses. So a CCT chest is nothing but an NCCT protocol taken along with another administration of IV contrast. So we would take a non-contrast scan first, we administer the IV contrast, we delay a scan by 55 to 70 seconds, allowing the contrast to enhance the soft tissues by giving an injection either through the hand with an injector or a bolus. Usually, whenever we do a contrast enhanced CT, we try to acquire images of the upper abdomen. It helps us in staging of lung cancers as well. And when you're doing it for PO evaluation, you should do a contrast enhanced CT chest and abdomen together. So these are the three images, the axial, corneal and sagittal taken after injection of contrast. You can see the contrast filling up the ventricle. Here also you can see contrast, which helps us highlight the mediastinal lymphadenopathy and the soft tissue in the mediastinum, as well as a sagittal image of the same. So this helps us to get three-dimensional localization of the lesion. There are other contrast protocols of which I'm just going to mention few, but in case you want more details on them, then I can prepare a separate short video for the same. We've all heard of CT pulmonary angiogram, which is performed for suspected pulmonary embolism, for follow-up of patients with pulmonary embolism, and for pulmonary artery hypertension also. And whenever we do a CTPA, we do a shallow inspiratory breath hold because we don't want a Valsalva maneuver causing a, with a deep inspiration leading to poor vascular pacification. So we do it in a shallow inspiratory breath hold. And CT pulmonary angiography is the gold standard in which we see the opacification of the pulmonary vasculature to look for emboli. The other is CT angiography for systemic arteries. We use it primarily to focus on the systemic circulation and not the pulmonary. So we use it for aorta and its branches. For example, evaluating a hemopsis or doing a pre-procedural imaging before a bronchial artery embolization is done, or you are suspecting aortic dissection, aortic aneurysm, or there are anomalous arteries, congenital malformations, like in a case of a lung sequestration, we want to know about the bronchial artery. And among these, CT angiography for aortic aneurysm, when we do, then we need particular protocols like ECG gated acquisition protocols as well. And multi-detector CT angiography of the thorax as a whole is being increasingly recommended whenever we have patients with hemopsis, especially when you're planning a bronchial artery embolization. A comprehensive evaluation should include a CT angiography of the thorax. So it's a very helpful test. It has certain protocols like the split bolus protocol or the triple rule out TRO-CT. Triple rule out CT is also an ECG gated examination. It is meant to look at the aorta, the coronaries, the pulmonary artery, and the mid and lower thorax, everything in a single scan. So essentially TRO. So essentially it's rules out acute coronary syndrome, it rules out pulmonary embolism, it rules out an aortic syndrome in case your patient comes in with chest pain to the emergency. So basically, it's a good rule out tool, so triple rule out or TRO-CT, and then further for hemopsis and for airway and vascular abnormalities, you can use a perfusion CT, a dynamic CT protocol also. So these are the other protocols, and mostly this summarizes what all we can order when we ask for CT chest, what it implies and what information it gives. So happy reading, and I invite you to read this article, which is a very good, very detailed article by some of the best radiologists who do chest radiology in India. So keep subscribing, keep liking and sharing, and I'll see you with another video real soon. Bye bye.